like so. To test ab and adduction, we'll keep the elbow in its resting position, about 70 degrees of flexion, stabilize the medial aspect of the ulna, of the humerus rather, and come onto the radial head. And we're going to have to push through the radius to test this movement out. And we'll simply stabilize the humerus and glide the ulna medially to test abduction, and then switch our grip around and glide it laterally to test adduction. Now, you're not looking for yards and yards of infill out of these medial and lateral glides, because there isn't any, obviously. Rather, what you're looking for is an abnormal infill, and this is often very hard. And it just indicates that the humerus isn't the ulna isn't gliding medially and laterally as it should do, and so it's restricting either abduction or adduction, which in turn will restrict flexion and extension. If we look at treating this joint now, this is abducted. If we want to take it into adduction, one way to do it is basically to stabilize the humerus and simply force this over into adduction. Very effective, as I say, but essentially dangerous. We stand a really good chance of rupturing stuff on the lateral side of the elbow. We could come in and attempt to do a lateral glide of the ulna and try and push it across that way. Very safe, but not very effective. So we're going to compromise and do a fairly effective technique that is also fairly safe if it's done correctly. What we'll do is bring the patient's arm around your chest that way so their fingers are flat on your chest. We'll bring the thenar eminence up onto the medial epicondyle of the humerus. Take the arm out of full extension, so you just flex it slightly, okay? The direction of thrust will be actually to abduct the humerus on the stable ulna, which will have the effect of adducting the ulna on the humerus. So we have a short lever osteokinematic technique that will result in gapping on that radial side and hopefully correct this abduction subluxation. We need some assistance from the patients though. So we'll have the patient do a little bit of work for us, and I'll get the patient to pronate their hand into my chest, just gently, and relax. As she relaxes, I'll just take up the slack of that gapping, and again, and relax, take up the gap, and then when you're ready to thrust, you simply thrust a short amplitude movement across the elbow. Okay. Having done that once, recheck. This doesn't always click when you do it, as all manipulations don't, but this one in particular doesn't always click, and you'll correct it often without any noticeable sound. The abduction manipulation to correct an adducted ulna is essentially the reverse of the one we just looked at. We'll bring the patient's arm onto the other side of the body, like so now. We'll bring the hand, the thenar eminence, onto the lateral epicondyle of the humerus. Take it out of full extension into a bit of flexion and bring her into this position. Now, the problem is that, is that the elbow will cause rotation, medial rotation of the arm as I try and do this. So I have to overcome that, and I'll do that by laterally rotating the arm first. Bring it into that position so it's stable, and I can feel that the elbow is not going to go anywhere except where I'm going to thrust it. I'll have the patient help me again, supinate into my chest the other way, good, and relax, take up the slack, and again, take up the slack, and then we'll simply thrust medially, like so. So we adduct the humerus on the stabilized ulna, in effect abducting the ulna on the humerus, there.